Good evening, everyone. Welcome. My name is Shirley, and I will be your moderator this evening. I am excited to welcome Dr. Samuel Kratchman, a practicing endodontist and renowned speaker, to discuss the pivotal role of CBCT imaging in assessing and treating root canals, fractures, cracked teeth, and more. Before we get started, I'd like to take a moment to go over some quick housekeeping. If you have a question, please type it in the Q&A section, and we will answer them live at the end of the webinar. This webinar is sponsored by J. Morita. CE is not available for this webinar, live or on demand. Dr. Kratchman, welcome, and thank you for being with us tonight. I will pass it over to you now.
Thank you very much, Shirley. And I won't make you say CBCT 5 times fast. Welcome, everybody. Unfortunately, I can't see you. I always like to lecture in person and see the faces that I'm speaking to. So hopefully in the future, we can do these types of seminars live. It's my pleasure and honor to be here. I want to thank Shine for the invitation. And also a special thanks to Jay Morita, specifically Joe Gober is my friend and colleague and extended the invitation to me. So I have a lot to get to tonight. We're going to, here's the outline. I'm going to speak to you for about 45 to 50 minutes. And we have a lot, I probably have about 80 slides to cover here, very clinically oriented. And also designed to really talk to general practitioners. I've done these seminars before, and a lot of the cases are geared more towards endodontists, but I know my audience is going to be mostly general practitioners, so I want to focus on that. And these are the different parts that I'm going to discuss, and with each of them, it's the role of the cone beam in discussion. Now, why is the cone beam so important? Why is saving teeth important? Remember, I'm talking to you as an endodontist. I teach 2 days a week at University of Pennsylvania, and then I'm in private practice 3 days a week. I have 4 offices outside of the Philadelphia area, 7 doctors. I'm the old guy, and we have 3 cone beams. And they happen to be J. Morita cone beams, not because I'm a consultant or get paid by J. Morita, but after researching it for many years, that was the machine that I found to be the clearest. But getting back to looking at this slide, and this comes from a dear friend of mine who's a prosthodontist in Heidelberg, Germany. Half these teeth here are implants, okay? So everybody look closely, and can you figure out which teeth are the implants here, right? And you don't get to see dentistry like this every day. Like, this is important. And maybe around 2000s and early 2000s, so many of these teeth were being taken out and being replaced by implants. But I have to tell you that over the last several years, I have found that patients are much more motivated to save natural teeth, and dentists are realizing that doing work like this that I just showed you is not easy, especially in the aesthetic zone. So my friend Marius, because he is such a well-known prosthodontist in Germany, gets these cases. These are those bottom drawer cases where you can see pink acrylic here. You can see part of the implant showing. You can see these cases which are scary, right? These are cases where we're trying to do a good job in the aesthetic zone with these patients, and we don't realize that, you know, just taking a tooth out and slapping an implant in is good enough, right? These are situations that we want to try to avoid, and dentists and patients are much more motivated to save natural teeth. So the pendulum, luckily, is swinging in our favor and in my favor as an endodontist in saving natural teeth. Now, before we get going, I always like to warm up the audience with a fun, or in this case, a crazy video. And about a month ago, I was doing an apicoectomy, an apical surgery on a patient. She happened to be a pulmonologist. And all of a sudden, like, I'm giving her local anesthetic about to get working. And she starts like panicking. She's like, "Doc, you're not going to knock off my crown. I was doing a upper molar, tooth number 14. You're not going to like dislodge my crown or anything, are you? And I'm like, no, I'm working above the tooth. I'm not even drilling on the crown. That's the beauty of the apical surgery. I'm like, why you seem so nervous? She's like, a colleague of mine just told me that a patient came in who had a crown, and the dentist, as they were trying to cement the crown, it slipped out of their hand, went into the patient's mouth, and instead of swallowing the crown, the patient aspirated it. And my colleague, a pulmonologist, had to remove the crown from the patient's lung. So this video you're not going to see every day. This is down in the lung. You can see actually the branch where the two bronchi, see there where it splits. And they tried this probe that was made out of metal to grab the crown, but it was too slippery. So then they ended up doing this cryotherapy probe, which you're going to see right here. And she said that the most difficult part was getting it past the vocal cords. And you can see on the right there, success where the crown was dropped into the little glass bowl. So, all right, let's get into this. Everybody now is saying, oh my God, I can't believe that. And believe me, none of us want this to happen. But now we're all warmed up and ready to get to work here. So yes, the cone beam is an expensive investment, but similar to my microscope, similar to my drills and ultrasonics, the cone beam now has become very important that I use every day of private practice and every day when I'm teaching down at Penn. Now, can the cone beam pay for itself? I don't look at the cone beam as something that I bought to make a lot of money off of necessarily. I look at it as something that has helped me unbelievably in diagnosing and treating cases. And I'm going to share many, many of those cases with you tonight. But this is just an example. And I'll be totally upfront with everybody. I charge $180 for a cone beam, plus $180 for an evaluation. I do accept some insurance plans, but insurances don't usually cover the cone beam. So when a patient is scheduling just for an evaluation, we quote them $360, of which 180 is going to have to come out of their pocket because we don't anticipate that the insurance will pay for a cone beam. If it does, then we'll reimburse. So this is a day that I did 9 cone beams mixed in with all my regular cases. And do the math. It can pay off, but it can pay for itself, if you would. Now, why I happen to like the Morita, and as I said, I'm not a paid consultant for Morita, so don't get me wrong. But it's like if you go to a stereo shop, you sometimes say to the person working there, "Oh, what kind of stereo do you have?" So if you ask me what kind of cone beam do I use, it's Morita. And we have it at both Penn and in my private offices. And I just find that the clarity is there. Now I'm going to share this, which is not from Morita. And I have a dear colleague who's an endodontist who sends me a lot of cases that I do surgery on. And he often does the diagnosis for me. And he'll send me slices from his cone beam to help. And if you look up here at the slices from his machine, I was nervous that this is the only bone that could be covering the tooth. And I'm like, wow, this is going to be a difficult case for me to deal with. This is more of like an endo-perio case. And then I did my submarginal incision, and this is all bone, right? This became a very routine, easy case. So what's the story with why this looks like this completely bone denuded? Here is the periapical lesion, when in fact it's really, there was a lot of bone there, okay? Now, my newest office, which I opened December of 2022, I have the newer model called the X800 of Morita, and it has a this artifact reduction in noise. So noise is similar to the term artifact. It's scatter. It's especially when you have metal objects like a porcelain fused to metal crown or zirconium crown or metal posts or even gutta percha or implants, even if it's not right next to the tooth, you get a lot of scatter. So if you look at the two left side circles here, this is what is referred to as scatter or noise or distortion. And it's very difficult to get a clean reading and to get a good diagnosis. Look at with this noise reduction, especially here, how clear this is with this newer model of the machine. So it's something that's very important and been very helpful. The other thing with this X800 is that the typical cone beam size that I take is a 4 centimeter by 8 centimeter, 4 by 8. So it's more like rectangular. Now, other machines that I've seen, if they take a larger size cone beam, it tends to distort the image when it's a bigger, imaging. So the beauty of this is, for example, this case here, a patient comes to my office, dentist says they want me to evaluate both upper and lower anterior region. So instead of having to take two separate cone beams, this has the option of taking an 8 by 8 cone beam. So it's hitting both the top and bottom. And then very easily, I'm just going to go, and I'm not a computer whiz, so whatever I show you is just stuff that is fairly easy to do. And basically, you box the area that you want to look at and then double click, and this is the imaging. So it's blowing it up for me without distorting the images. And then I typically, what I do here is I like to measure the size of the lesion. My cutoff, if I'm going to do apical surgery, usually if lesions are around 7 millimeters in diameter, it's not going to heal spontaneously from conventional root canal. So I have to warn the patient that maybe a good chance of doing surgery in the future. And then the same cone beam, I box the lower anterior region. And once again, these are very clear images. Look, this is important. Look at this lower anterior tooth. It looks like it starts off as one canal, becomes one large, broad canal in a buccal lingual dimension, and then becomes one at the end, right? So this is like your GPS. This is your mapping of what you're going to expect before diving in and doing root canal. Do I take cone beams on every case? No, I do not. I take them on every retreatment case. I take them on every surgical case, and I take them on a lot of diagnostic cases where now dentists are sending me to say, Sam, please just do the diagnosis here and let's see what's going on. And we're going to keep on going and showing several of these. Now, this stuff drives me crazy. These are real cases that have been referred to me, and I'm just gonna, you could read it while I'm talking to you, but what cracks me up, and I kind of put this, with parentheses around it, all the time I read reports from dental radiologists, and it could be like a 7-page report about 1 or 2 teeth. And to be honest, I hate to say this, but there's very little information that's helpful to me as an endodontist in terms of, do these teeth need endodontic treatment? And I love it because they always say area of low density, which is radiolucency, right? Area of low density usually means that there's a lesion, the tooth is necrotic and needs endodontics, suggestive of possible root. So they use words like they're afraid to say, hey, there's a shadow around the root, do the root canal, all right? I get it, things like this, areas suggestive of possible this. And you see here, how could you diagnose from something that's blurry? This comes from a dear friend of mine who's an oral surgeon, great guy, great surgeon. And I said, can you send me, a slice so I don't have to take a cone beam? And he's like, yeah, can you look at tooth number 21? And he took this picture on his computer of his cone beam. And he's like, Sam, can you, diagnose this? And I'm like, come on, I can't even see, what's going on. And I don't know if he's not a good photographer or it's just a very blurry image. Now, when I take a cone beam, and this is very easy, I'm just going to go through a couple of very simple steps here. I'll tell you what I do is I take 2 minutes and I develop a, report that I'm going to email to you. If you're sending me a case, I'm going to email you a quick report. It takes me 2 minutes after I see the patient. And let's just look at this example. Patient comes into my office with some complaint of some diffuse pain in this area, lower left side. First thing pops out of my head is maybe there's a perforation in the furcation of this molar, but she was pointing more in this area when I palpated. Looks totally normal on periapical film. Look at this when I take a CBCT. This is the lingual of the tooth, and there's a big pocket here and probing depth over here, and that could be indicative of a fracture. So I want to point this out to the referring dentist, or if you need to send a report to an insurance company or to a colleague, or let the patient see what's going on. It's their property if they want to see their own cone beam. I show this to the patient, and all I do is go in the middle here, right click, it says copy all images, and then I paste it onto my desktop and import it into their chart. Over here, if you click on this, there'll be the option of doing an arrow on the case like you see here, or you also can put some printing here. So here is that little box, you right click, it gives you the option to put an arrow, click on that, and then you place the arrow where you want to point out for dentist or for patient to see. And if I want to write something on here, I go down to that same box, click on the T, the text box, and then it gives you a little white box here, and I click in lesion. So I'm trying to point out that there's a lesion there. Simple, takes 2 seconds, and it's so much nicer than when a patient comes to me with a CD of an entire scan, and I don't even have a CD drive in my office, and they say, Dr. So-and-so wants you to evaluate tooth number 2, 5, 10, 21, 23, and they hand me a disc. I don't have a CD drive. I don't know the software of that particular brand. And to be honest, it's probably going to be a lot blurrier than mine. And patients are, concerned about radiation. They don't want me to necessarily take another cone beam CT. So that's a dilemma. And I just want to say that it's so easy to communicate and send reports with this. Okay, now let's get into the cases. And these are all new because I know I did a similar lecture about a year ago or so. Some cases I may show that were from last year, but almost all of these are new within the past year. It shows you how many of these funky, fun, cone beams coming in almost every day into private practice and at school. So this case here was an ortho down at Penn. And they're trying, you can see they put brackets on, they're trying to move these teeth and they're not moving and they're wondering what's going on. So they send to endo. Ortho even likes our Morita cone beam machine in endo. So they'll send cases to us just to do the cone beam. We take the cone beam, look at this. These teeth are fused together apically. And I have to say, I've been practicing now 33 years. It's the first time I ever saw anatomy like this, where literally the roots are fused together, and this answers the question why ortho couldn't move these teeth. So these lines here, what I'm doing is we're in a process down in the Prosto lab at Penn at doing some 3D printing. My dear friend Dr. Canyejo is going to make a 3D print for me and for the resident of these teeth, and the 3D print is basically going to help us to decide where I'm going to make these cuts, right? Because what they want us to do is separate these teeth so that ortho can then move the teeth. So because we're literally cutting the roots off, the tips off, we're going to have to do 2 prophylactic root canals, and then we'll be able to cut them and then hopefully separate them and send them back to ortho for movement. This case comes from a referring dentist. He's was a little pushy. He wanted me to, he said, there are 2 lesions. I want you to do 2 apicos for me. And the patient is going out of town and he wants it done, ASAP. So, he's putting pressure on me. And this is important. If you just have this patient come in and you're only looking at the 2D picture here, all I see is two lesions, fat posts, right? I'm not going to do retreatments here. These are slam dunk apicos. I could do these apicos 15, 20 minutes. It's easy. If you rush in and did that, this is why you're going to be in trouble. The cone beam on this central shows that the lesion is palatal and it's going right to the area palatally where that thick post is. You can see the post is slightly off axis. Is this a perforation? I'm not sure, but if not, it's pretty darn close to one. But on the adjacent tooth, 100% this is a perforation because you could see the post is deviating, and there's also this area here of low density or the shadow. And yes, there could be some artifact here, but definitely there was mobility here, and this tooth has to be extracted. So to be honest, the most sorry about the puppy there. My wife's coming home. The most predictable thing here would be to probably extract both of these teeth, not risk saying, let me try to save this with an apicoectomy and then having trouble down the road if this lesion doesn't heal and it's next to a new implant. So this should be extract both these teeth and either implants or bridge. This is interesting because the patient came in. It's actually a young man in his 20s, and I'm just seeing if I could get this out of the way here. And sorry, let me go back. And he, sorry, did I just mess something up? And let me go back here. He comes in and he was a soccer player, actually know his father very well. And he had a little bit of discoloration, but no symptoms. So the dentist was worried that this was an abscess tooth. He didn't really have a chief complaint, but look carefully here at the size of the canals. Remember, he's a young man in his early 20s, and this is a typical size of a canal from somebody that age. And then look at the adjacent tooth. So he had a history of trauma, playing soccer, right? You know, the kids, my son, never wore mouth guards because you can't breathe or talk with a mouth guard. So he didn't wear a mouth guard when he was young. He ran into some problem here. So the question is, if the coloration is bothering him, you want to internally bleach. In order to internally bleach, you have to do a root canal. This is a sterile necrosis, I call it. It was negative to cold, negative to electric pulp test. So yes, it is necrotic, but sterile. There's no lesion, there's no symptoms. So something like this, there's no correct answer. External bleaching is not going to work. And maybe a veneer is good. A veneer, is difficult to do on one tooth. We have to do two veneers to try to solve this problem. So a little bit of a dilemma here, but interesting cone beam clearly showing the difference between these two canals. Now, this patient came in. He's a physician, young gentleman, low 30s. His wife is one of my big referrals. She's an aesthetic dentist in my area. When he was young, his baby brother was swinging a hockey stick, not looking that he was right behind him, and whacked him in the tooth with the face with a hockey stick. So he has the central and lateral non-complicated fractures. They have a very deep fillings and it's huge lesion, almost 8 by 8, 8 millimeters by 8.8 millimeter lesion. So ironically, or very interesting, I should say, the lateral incisor tested positive. It was responsive to cold. And I do use electric pulp test on these anterior teeth, especially if there's a history of trauma, to see if there is, any sense of vitality. So I did the root canal number 9 on the central incisor, opened the canal, and it's completely void of all tissue. There was just like a foul odor there, but no pus, no drainage. I still do necrotic teeth in 2 appointments. And I explained to him, look, we got to keep an eye on this. You can get this central restored. You can get veneer. His wife's going to do, I think, a crown on the central, maybe veneer on the lateral. And then if this lesion does not heal and we decide to go in surgically, I'm most likely going to do a root canal on the lateral incisor because I don't want to devitalize that when I'm going in surgically. Okay, so an interesting case. And even though the lesion looks like it's around that lateral, it actually is testing vital for the time being. This case also just added this. Patient came in 2019 with these two x-rays sent from his referring dentist, who's a dear friend and a great referral. She traced fistula into the furcation. So this is a perio tracing, not necessarily endo, and circled this area where she was afraid that there was a perio lesion, possibly a root fracture. Now, there was not deep probings here. Clearly, there's a periapical lesion. And look at the pre-op cone beams. So look up here where I'm circling. Furcation lesion going down into the apex, mesial root, small lesion on the distal root. So my initial diagnosis was endoperio lesion. Did the root canal retreatment, 2 visits, and then patient disappears, doesn't have any perio treatment done, no scaling, no root planing, nothing. Patient just comes back a little while ago, 2023, and I take a new cone beam and look at this, compare the furcation from here, 2019, to current 2023. Now, yes, there still is small lesion mesial root, but it got smaller since 2019. Distal root insignificant. I'm not about to go in there, but for now, I'm not doing anything, right? He's not symptomatic. And look at the amount of healing from just doing root canal. So what this tells me is that my initial diagnosis was incorrect. The true diagnosis, my final diagnosis, pure endo with a very good prognosis, whereas in 2019, I had endoperio with a guarded prognosis to it. So very interesting how this cone beam shows the healing, and especially healing in the furca with just doing root canal. Here's a perfect example of a way that I could have been not trapped, but mistaking if I jumped in and did the treatment without doing 3D imaging. Patient comes from referral. Also, I keep on saying good friend, great referral. It happens to be a very close friend of mine. And he says, Sam, the fill is short and I see a lesion here. I'm sending him to you to, do a retreatment of the root canal. And the symptoms were very mild, but little percussion sensitive. I take a cone beam and look at this. The lesion is barely anything on the mesial apex, but the lesion is going down the lingual part of the root. There was not a deep probing here, but this is clearly perio, separate from the endo. So if I would have just jumped in and done either an apical surgery, which I wouldn't have, or done the retreatment, nothing would have happened. That wouldn't have healed, and the patient still potentially would have had symptoms. So I did their nothing, and then I referred to a periodontist who actually comes into my friend's office once a week to explore that area, either surgically or do a scaling or root planing to try to reduce that pocket in their area. Okay, so a retreat or apical would not have done anything. This patient comes into my office, and here's the 2D image of the second bicuspid. She's having some pretty significant pain here. Looks like post in one canal, nice looking filling, maybe a little short filling in this canal. Take a CBCT, canal's completely missed. The buccal canal is completely missed. Palatal canal looks good. And what they thought was a buccal canal was instrumented through the furcation and perforated. So now the treatment becomes a conservative retreatment. Try to remove this gutta percha, get into the buccal canal, treat the buccal canal, and then seal this internally with a bioceramic putty to try to get some healing over there, okay? So this is something where you really can't tell what's going on from the initial cone beam. I just put this one in because it's kind of a cute thing here. Patient comes in to evaluate tooth number 14, whether something's going on with the mesial buccal canal. You can see here, there's definitely something happening. Look at the configuration here. It's really crazy. 12 is right here. 13 is tucked back. So you never want to have to do a surgery on 13. Here is the mesial buccal, distal buccal palatal of 13. But this is really what I'm doing. This looks like some kind of a cementoma or condensing osseous fibroma there. This is benign, and you just keep an eye on it. But look at this. This looks like a fetus. Looks like a baby boy going there. That's why I'm showing this to you. And what's important, and I'm going to bring this up a couple times in the presentation, is this is a video of how I look at a cone beam. So it's nice when you send like an individual slice of the cone beam to your referring dentist, but you really want to be able to scan it and show the whole, look up and down. And if you look here, let me go back tiny bit. Right here, you could actually see that that's a tooth. It's a supernumerary tooth. There is the enamel of that tooth up in the sinus. So very interesting. I'm not going in to get that out. If you feel that a lesion is developing and there are any issues there, I'd most likely send to an oral surgeon to do a case like that. This patient comes in, had the root canal done by a colleague of mine, by an endodontist. Root canal looks perfect on the first bicuspid. The patient has continued symptoms, keeps on going back to the endodontist, who keeps on telling them there's nothing I could do and keeps on putting the patient on antibiotics. Now, statistically, you have to understand something. And the endodontist did all three of these root canals. Beautiful job on the molar, 4 canals treated. Beautiful job on the second bicuspid, which typically will have 1 canal, but he found 2 canals. He should have known that a first bicuspid is always going to have 2 canals, sometimes even 3. So I take a cone beam CT and look, the buccal canal of the first bicuspid is just simply missed. But unfortunately, my friend didn't think, well, let me try retreating it. Like, you cannot have an ego. If something's not working for your patient, I don't care if I have to redo my own work. I do it for free, right? If there's a problem. Now, yes, this tooth is tricky. It's rotated here. And that's what I'm sure confused him. But in 2 seconds, I could see the problem. And the patient was on 2 or 3 different regimens of antibiotics, kept on swelling and having problem. Here's my final, and this is kind of crazy because here is the palatal root of the first, and there is the buccal of the first bicuspid. So it is a rotated tooth, but nonetheless should have been retreated. This case, my dear friend, Dr. Bras, shared with me. One of my residents practiced up in the Boston area. If anybody is watching from Boston, I'm not rooting for your Celtics because I know they're going to beat my 76ers in the next round. So sorry, guys. I'm not a big Celtics fan. So Louis did this beautiful root canal, and the patient ends up getting temporary paresthesia. And if you look at the cone beam, look at how close the root tip is of the second molar. It's right in the mandibular canal. And Louis was using a eugenol-based sealer, like a Grossman cement, and eugenol happens to be neurotoxic. Now, I knew it wasn't going to be permanent. I told Louis not to worry, but nonetheless, this is something that you keep an eye on. And as you can see here, he put the patient on corticosteroid, and the numbness went away within 3 months. So I'm going to skip over this. I've shown that before. And here's a crazy one. Patient comes in, and this is my former resident, Garrett, out in San Diego, takes this crazy looking cone beam and looks like something is floating here out in space. Sends this to oral surgeon, the cone beam slices and the slice from the Panorex. With this Morita machine, by the way, they take what's called a Scout Panorex. So every patient gets a Panorex film, and that is what you use to calibrate the actual CT. So you take a Panorex, And then this +1 means you're going to box this area because you're focusing on the lower second molar. And they saw this radio opaque area, which is diagnosed as a gland in the submandibular, a stone in the submandibular gland, which either you do nothing or if anything became symptomatic, then you're going to have to take out the whole gland. So hopefully that doesn't become a problem. Okay, next topic. Let's talk about the cone beams actually change my treatment plan on cases. Okay, so let's take a case like this. Patient came in, and this is also from an old faculty member of mine, older gentleman, was an endodontist, does not have 3D technology, did nice root canals, but if there were any problems, he would send them to me for either retreatments or surgery. So he does this root canal. This is his regular periapical film. Here's my digital film. Nice job. And he says, Sam, patient is symptomatic. Looks like there's a lesion on the mesial root. Can you do apical surgery? And I'm like, sure, I can do apical surgery, but let me first do some imaging just to make sure. Do the image, and clearly what we're seeing here is a missed MB2, okay? So this is the axial view, distal root, palatal root, mesial buccal, and you'll hear doctors refer to this as a second mesial buccal, MB2, mesial palatal canal, and this root is shaped like this. The body is very symmetrical, so if you see this kidney bean or figure 8, and you see only one canal, there's got to be another canal, and sure enough, when you look at the coronal view, here is the mesial root, and there's an MB2. Now, let me just show you real briefly. If I was going to do a surgery, here I'm cutting off, this is my Lindemann burr that I use for apical surgery, cutting off the tip of this root. I teach all my residents cut off 3 millimeters of root, but then I'm barely addressing the MB2. Then I have to go dip down like that to get to the MB2, level it off. Now I'm sacrificing the crown root ratio. So definitely you have to do a conservative retreatment here. So the cone beam helped to teach me that I'm not going to go aggressive and do surgery. I have to do a conservative retreat. And basically our goal is to get about 3 millimeters, take off about 3 millimeters of the root, and then prep another 3 millimeters with ultrasonics. And in cases like that, you're going to affect this crown root ratio. You're going to end up having to cut off over 6 millimeters of root to get to this MB2 when the root is shaped like this. And therefore, you always should do a conservative retreat on cases like that. And this is what an MB2 will look like when you go in conventionally to do the endo or the retreat. And this, once again, is the shape oftentimes that you see on the cone beam, and the lesion is wrapping around palatally of this mesial buccal root, which is shows that there's a whole missed canal. And then here is the view that I did this case with 4 canals treated. This patient came into Penn. One of my residents was thinking of doing apical surgery here. She took a cone beam, and this is a video that we make showing that we're scrolling here. And if you look closely, so I'm scrolling with the green line up top, but I'm looking down here, and you can see that the mental foramen is coming out right where the lesion is of the tooth. And you can see with this arrow here, this is the lesion, this is the mental foramen where the nerve comes out. So there's no way we're touching this with surgery. So treatment plan becomes a conservative retreat because you don't want to risk paresthesia for this patient. This case I love to show. Resident comes to me. She's like, Doc, look what we got here. The pre-op shows a lot of stuff. Molar done. There's a perforation with this palatal post, which I'll show you on the cone beam. Broken file in the distal root. Mesial root short. So we take a cone beam. Look at all this mess we got to deal with here. A big lesion coming from this perforation of the post on the palatal. Okay. We're going to retreat. And when we retreat, they take the post out. We fill this perforation. First, we put out a little bit of collagen tape to kind of get a seal and a barrier. Then we put fast set bioceramic putty here. retreat the mesial, try to retreat the distal and get the separated file out, but can't get the instrument out. So we say to the patient, okay, let this settle for a bit. I want to see that how healing is, but we're going to go in most likely surgically and take care of it. And my residents love to do surgery. So they're dying, the patient to come back and the retreat to be failing because we can't get this distal buccal file, separate file out and do surgery. So look at this. Takes a cone beam a year later, everything heals. This just from sealing the perforation. So this is that bioceramic putty sealing it. All this bone filled in. Here's the 1-year follow-up on the mesial bone fill. So let's compare, right? So here is the pre-op cone beam with the mesial. Here's a 1-year follow-up, complete healing. Look at this palatal, right? Big lesion from the perforation. By sealing the perforation, retreating here, it got healing. But this is the part that cracked me up. Here is the pre-op of the distal buccal root with the separated file. We couldn't get out separated file. Distal buccal healed. You know what that means? That the whole lesion, this lesion was actually coming from the palatal going towards the distal. And I said, Tom Root, I'm sorry, you did too good of a job that can't do surgery because you got it to heal. So as much as she wanted to do surgery, obviously I'm not going to let her do surgery. Okay. Next topic, we're moving quickly. I'm ready. I can't believe I only have about 10 minutes left or so. Talk about resorption. I see this almost every day in practice. This and cracked teeth. So we're going to talk about resorption and cracked teeth. Now, the important thing is resorption is one of the main reasons you have to take a cone beam. You know why? Because you have to determine not only the extent of the resorption, but the location. And when you look at a regular look, you look at a pre-op periapical film, I can't tell this is on the buccal or palatal or how deep it is. The cone beam shows this is on the palatal aspect of the tooth. That's a negative in terms of reaching it, but it's a positive in terms of I'm not so scared raising a palatal flap that there's going to be recession in the aesthetic zone, as opposed to if this was on the buccal, then you're dealing with a situation where you're really risking raising a flap and having some recession, especially because we're using a Jerry Store, glass ionomer type of material. So here is my palatal flap, the defect, sealed it with Jerry Store, pre-op, post-op, 2-year follow-up. Critical that we take cone beam. Now, generally speaking, dentists just throw the word internal resorption out when they send me a case to diagnose. And I have to say, over 90% of the cases that I see, like the previous one, and like all the next ones I'm showing you, are external resorption. External resorption is an inflammatory process from damage to the PDL. Internal resorption, which is much more rare of a situation, you're going to see on a cone beam where the canal is disturbed, right? So actually, this would be necrotic. This is the coronal view of this tooth. This would be necrotic. Now you get into this big resorptive defect. You see the ballooning out of the canal. And believe it or not in this case is necrotic, but sometimes these early on, it still could be vital tissue here. But the key is the ballooning out of the canal. That is internal. All the other cases that we see are these external cases. Now, what's interesting is that the pulp always wants to protect itself. So as much as these defects look a little bit crazy, look over here real carefully. The defect is coming through the buccal of this tooth and it's being walled off. So look at the pulp. The pulp is laying down some dentin to protect itself, to wall it off from the insult. So do these cases need root canal? Only if you're going to go in and fix this defect. Because if you just do a root canal, considering the fact that this is external, the resorption is not going to heal because it's not coming from the pulp. This is derived from damage to the PDL. Therefore, you need to have access to it, to clean it, and to restore it. And if you're going to operate here, you need to make sure you're cleaning everything out. So, of course, you're going to have to do the endo in something like that. Okay, this is great. The resorption starts coming in here. There's always going to be an entrance point, goes towards the pulp, stops, comes in this way, goes towards the pulp, stop, this way towards the pulp, stop, and it never invades the pulp. and look at how the tooth is practically destroyed here. In a lot of these cases, you just observe, and then you say to the patient, look, if it becomes symptomatic or any issues, then we can do the treatment, or unfortunately, a lot of times these end up being extracted, okay? This case, I got lucky where patient was sent to me to do the root canal on the upper second molar. I was about to start, but this looked kind of strange from the wisdom tooth coming in. Thank goodness I took a cone beam, because the wisdom tooth actually is resorbing away the entire root here. And if this is the palatal aspect of the root in the axial view, if I were to do a root canal here, I'd be floating into space. I would be perforating out the palatal side of the tooth. And you know what's even worse is that I can't use hypochlorite, or else I'd have a hypochlorite incident. Okay, so that's very scary and something to be very aware of. Next topic we're going to talk about is cracked teeth. I have to talk about this. I'm going to finish up in about 5 to 7 minutes. So I apologize. I'm going a little bit longer, but this has so much to show you. And I can stick around for as many questions as possible. So timing is not as worrisome for me. So I apologize if I'm going a little bit over, but I don't want to stop. I have, a few more cases to show you. So very important to know, the predominance of where fractures happen. Most likely lower molars, as you can see, but maxillary premolars are second to lower molars in terms of location of fractures. And this is due to the fact that maxillary molars are fairly narrow roots with large, occlusal tables, and very common to show cracks. And especially when patients are having root canals and large posts placed in them. Here's an example of an upper bicuspid. You can see there's a large post here, and this arrow is pointing to what looks like a fracture to me on the palatal aspect of the root. This could be tricky. If you want to know this for sure, instead of just saying the tooth needs to be extracted, you need to do a small palatal incision and see if you can visualize something like that, okay? Now, a couple of tricks here is that if you're about to take a cone beam here, when you have a metal post, you're going to get a lot of scatter. You also have the lip that can superimpose some imaging, even though it's soft tissue. So what we do is we put a cotton roll under the patient's lip into the vestibule, and this keeps the lip out of the way, and now gives us a little bit better view to see whether there is a potential crack here. So this is the cotton roll trick I call, putting a cotton roll in the anterior region to try to keep the lip out of the way. Another trick, and this is clever, is, we use a tooth sleuth or a bite stick to demonstrate possibility of a fracture. If you suspect a fracture, have the patient bite on a wooden stick when you're taking the cone beam. And what it's going to do is separate the pieces of the tooth where the crack is. And this is a transillumination where I'm using the fiber optics to show that it's shining through this part of the tooth, and you don't see the light here, meaning that there's a crack across the whole half of this tooth. And by having the patient bite on that stick during the cone beam, you can see that there's separation of the two pieces. So that's a nice little trick that I want everybody to be aware of. And what happens is that a lot of times you can see cracks on teeth. So when I take a cone beam like this, I show that when the bone loss is not apically, but along the root, the side of the root, the lateral aspect of the root, or if there's a single deep pocket, then I'll send something like this to the dentist saying the bone loss here is suggestive of a fracture. If the patient is just in for an eval, not opening the tooth. When you open a tooth like this, you can clearly see that the whole tooth is fractured. This is looking down the axial wall of the tooth. And a tooth like this, unfortunately, is going to have to be extracted, okay? Now, when we do something like this, I thought maybe there's a fracture of this tooth, but in actuality, this was done by an endodontist, comes from a great referral that's very astute, and he knew that there was a cast post and core. He said, Sam, can I, take this out for you? Can I make a new crown for you? I said, look, let me do an evaluation first. I do an evaluation, and the endodontist just missed the mesial canal. So I didn't even have to retreat the distal. There was no lesion there. And he was nice enough, the dentist, to cut off this crown, temporize it for me. And right when I went in through the buildup and removed the gutta percha and located the missed canal, look at all this pus coming out. So this is a missed mesial lingual canal, and all it needed was for me to do the retreatment of it. Last two cases I'm going to show, very interesting. This is a topic of replantation. I'm only going to talk about it for less than 5 minutes, and I guarantee it's going to raise more questions than the previous 45 minutes of my lecture. And I have an hour-and-a-half lecture on this topic, and these are cases where it's very difficult to reach, usually second molars, and there's problems. And in this case, patient comes into the clinic at Penn. My resident, Nora, sees this patient, takes a cone beam, and look at this mess. You have overfills like crazy into the sinus with gutta percha and some sealer. And the easiest root of all, the palatal root, was missed during the regular root canal. So, of course, we have to retreat this first. But how are you going to retreat these buccal roots? You're not going to be able to get out this excess material. It's floating in the sinus, and it's a second molar, which makes it very difficult to reach. So, and here are just some different views. So this is what we do. We extract the tooth. I have a whole lecture on this, so I go into all the details here. Now, Nora's working on the tooth outside the mouth. I'm working in there to try to get that piece of gutta percha out that's sticking beyond. There's the septum in the sinus. I actually have to break the septum in the sinus in order to get this little gutta percha extractor that I use, very sharp tool, to pull out the gutta percha. You'll see that in a second. Watch this. So I'm sticking this very sharp exponent, boom. And now I got that little wad of gutta percha along with the lesion and some excess sealer there. That's what it is. And then after that, we replant the tooth and say to the patient, look, number one, I think I got all the gutta percha out from your sinus, all this filling material, but be aware, something may happen. You may sneeze or blow your nose and see a piece of orange coming. The patient was the nicest patient. Patient calls us the next day, says, I feel great. I love the procedure. We replanted the tooth. I'll show you slides in a sec. I'm feeling really good, but I coughed up a little piece of rubber today and I saved it for you. So what was funny is that I expected that the piece of gutta percha that was dislodged in the sinus that I didn't get from the other root was going to come out through her nose, but it somehow went in and came out through her mouth. Okay. Here is the post-op of the intentional replantation. In this case, because of how short the roots were, there was some mobility, so we had to splint it. Ready for this? Less than 15% of the time we have to splint it because we take it out carefully, we put it back in, there's 0 to less than +1 mobility. So you don't even want to splint it. There's a 4-week follow-up. We took the splint off, and patient came back recently for a 6-month follow-up, cone beam with healing. I have so many cases like this, and you would think in this day and age, less and less of these are being done, when in actuality, we're doing more of these, because if this doesn't work, if I can't get the tooth out without breaking it, then we can always do an implant, okay? But with the truth coming out, the reality that not all implants work, that there's a lot of peri-implantitis or bone loss around implants, I'm doing more and more of these reimplantations, and they're so easy. This is my last case before I say goodnight and answer questions. And I put Dr. Dow here because this is my first year resident, and we just did this case 2 days ago on Tuesday. And I wanted to add it to you. And all of us in dental school learn how to extract teeth. So if you can extract the tooth carefully, and I have special forceps, and I talk about everything here, the forceps up here, but the purpose of the cone beam, why I want to show this, is the cone beam showed that there's erosion of the lingual plate of bone and big lesion here. So I use this to direct how I'm going to extract the tooth. Think about this. By luxating the tooth buccally in this direction, this root very easily can come out. If you're going to luxate the tooth in a lingual direction, then the root has to travel all this way buccally. So once again, we luxated the tooth in a buccal direction. There was already a break of the bone here. Tooth came out in one piece. We cut off the ends of the roots outside the mouth. We're bathing it in Hank's balance solution. We see the canals with isthmus and leakage here. Prep it with a high-speed BC putty. In 9 minutes, the tooth's back in the mouth. And I'm telling you, the success rate of these cases is remarkable. And I have so many cases, I'm sorry, don't have time to show you, but here is the success rate. Tor Binajad, who's a famous endodontist out in Loma Linda and chairman there, did a review of articles from 1966 to 2014, 88% success rate on reimplantation. And then in 2017, Mainkar also did a review, 89% success rate. And just read these last two sentences. Compared with a single tooth implant, intentional replantation is more cost effective, even when custom posted in core and crown is needed. And intentional replantation should be considered and discussed with patients, especially because an implant can still be placed if the intentional replantation is not successful. Whereas if an implant fails, that's much more catastrophic and expensive and time-consuming to a patient. Okay, sorry I had to talk fast. Sorry I went a little bit over. Last year I showed that this is my bar at my house, right off my kitchen. If you read my bio, I'm a professional bartender. I went to New York bartending school back at the end of high school when drinking age was 18 in New York. This is way back in the dark ages. What I haven't shown you before is that since this is in my house, here's my COVID hangout during the daytime. So the best thing about my bar is that it's open 24/7. So if any of you guys are in the neighborhood outside of Philadelphia, give me a quick holler. And as you can see, I'm not worried about running out of booze. So thank you very much. Here's my son and I at this year's Super Bowl. I'm a big Eagles fan, have season tickets to the Eagles. And for 58 minutes, I had a great time. And then the last 2 minutes were seriously devastating. Thank you, guys. And Cheryl, if you can come back on, then I'm happy to answer any questions. And sorry for going over by about 10 minutes.
Not at all. Thank you so much, Dr. Kratchman, for that wonderful and fascinating presentation. And now we are in our Q&A portion of the webinar. If anyone has any questions that you'd like to ask, we invite you to enter them into the Q&A box at the bottom of your screen. And Dr. Kratchman has kindly offered to stay over and answer any questions. If not, we will also be taking questions via email, and or you can put them in the Q&A box as well, and we can get you the appropriate answers. And Dr. Kratchman, there are two comments that I can go ahead and read to
Please.
you from an earlier part of your presentation. One is from Dr. Al-Julali, and he said, "That's reality in dentistry. Any crown can slip into a patient's mouth. We try hard for this not to happen." And this
Sure.
is in reference to the beginning part, your video.
Yeah, I mean, it's happened to me. The point of that video is that, you know, most of the time a patient will swallow the crown, or you just fish it out, obviously. The unfortunate thing, and the thing that makes this scary, I'm not saying the dentist did anything wrong. Of course, you know, you could drop it, but what happens sometimes is that the patient, just the reaction going like that, inhaled, and unfortunately aspirated instead of swallowed it. And that's the scary part. But it's just ironic that my patient happened to be a pulmonologist, and she was like, oh, she was such a calm patient. And then all of a sudden started getting nervous. And I'm like, what's wrong? And she's like, you're not going to drop my crown in my, and I'm like, no, it's if anything, I'm not even drilling on the crown because it was a surgical case. So yeah, I wasn't trying to slide anybody. We've all dropped things. It's just usually you fish it out, or at worst, the patient swallows it, not aspirates it. That was the scary part.
Yeah, that is scary indeed. Thank you, doctor. We have a comment from a Dr. Stephen Kaplan. A question: I missed the first 20 minutes. Can it be watched anywhere? Beautiful presentation. And yes, we will be sending out a link to this webinar, which has been recorded over the coming week. So you will be receiving this.
Thank you, Steve.
Well, it is the top of the hour, 8:01 p.m. On the East Coast. And unless there are any other questions, we do invite you to submit any questions you may think of later at webinars@henryschein.com. Again, that's webinars@henryschein.com. Hey, well, thank you, Dr. Kratchman, for a
Thank you very
wonderful
much.
presentation this evening. And thank you all for joining us tonight. As I said earlier, we did record tonight's webinar and we'll email the recording out sometime in the next week. We would appreciate your feedback via our survey that will pop up on your screen shortly. And thank you again for joining us. We look forward to seeing you on future webinars. Thank you again, Dr. Kratchman. That was
Thank
really
you,
fascinating.
guys. Thank you. Appreciate it.